goals and the agenda for this session is to demonstrate how quality asthma education and counseling can be documented and coded, and that requires necessary chart documentation to support those codes, and to help physicians and providers receive appropriate reimbursement for the quality asthma care they provide. And that entails, coding correctly on your encounter and billing forms. Despite the time that physicians and other providers invest in education and training, we tend to undercharge for our services. We also have been known to not document and code appropriately. That causes some problems that we're either undercoding and not being compensated for the work that we do, and it's a loss of revenue, or in some cases, if we're overcoding, we're overcharging for patient services, and there can be fines and penalties when that happens if you're unlucky enough to be audited. What some of the questions as providers that we should ask ourselves in looking at our practice, particularly since we're embarking on centennial care, we're responsible for managing a patient population. We need to make sure that all of our processes are in order. So look at your practice, and whether you're in a large practice or a solo practice, find out if your claims are getting denied, and if so, why. Make sure, when you're doing your medical record reviews, is your chart documentation adequate? Is it supporting your claims? And then if you're not using modifiers, if you're not coding for time, then you're probably not maximizing the reimbursement that you should be getting for the work that you're doing. So I understand that all of you are providers and have a long history of coding. We can just briefly go over some of the definitions. The CPT, the current procedural terminology, is what you do for your patients. The codes have relative value units that are determined by the Centers for Medicare and Medicaid Services based on the difficulty, the complexity of your work. The ICD-9, and I know some folks are using ICD-10 currently. That's the problem, the condition, the diagnosis that you make for your patient. And all of these codes define the medical necessity of the services that you provide. The only point on this slide I want to make is that definitely you can have more than one CPT code, and definitely more than one diagnosis. I think most systems will accept 4 diagnoses at least, and multiple CPT codes. And just make sure that they're linked. If you have an OB code linked to a male patient, which I know has happened, it's going to get denied. There are silly mistakes like that. But if in this case you've seen a patient with asthma exacerbation, it should be linked to the appropriate visit code, this is an expanded CPT, the 99214. So just be real careful about that. There are so many different complexities for selecting codes. There are codes for inpatient and outpatient services. For new office visits, there's 5 levels of complexity. 1 is the least complex, the lowest value. 5 is the most complex with the highest value. Establish office visits for patients that you have already established a relationship with. There are 4 levels of complexity. I do want to make a note that 99211 and 99201, particularly the 211, does not require 3 components of history, does not have a high level of a physical exam or medical decision making. So that really leaves 4 levels of complexity for the established patient. And generally, I think the 99210s and 211s are almost like nurse visits. You know, the patient's coming back for a weight check, they're coming back for a blood pressure check, and it's or an O2 SAT or something like that. So it's done under your license, but it's not a real medical visit. And they should be few. Okay? So, let's see. Let's move. Did I skip a slide? I'm sorry if I did. I don't think so. No. For complexity of history, as I said, there's 4 levels from problem focused to comprehensive. I think you're all fairly up to date on this process. If anyone has any questions, please interrupt me or make any comments during this presentation. I think it's important to note for both the comprehensive visit that it really is a full history of present illness, past family social history, and a review of systems of all 10 organ systems or body areas. And same for the levels of physical exam. You know, if you've been doing this work for a while, you might be stuck, and you might be using a lot of 212s or 213s, and you're undercoding. You're not getting the revenue that supports the amount of time and expertise that you've provided to the patient. So if you find that in most of your visits you are examining 2 to 7 body areas or organ systems, be sure you're coding to that level. For the comprehensive physical, of those 8 organ systems, one of those 8 has to be the mental status exam and the neurological exam. If it's not, then you shouldn't be billing at the comprehensive level. Now that's for primary care. There might be, and tell me if I'm wrong, with specialty care, is that also true that you have to include the neurological and mental status? You're shaking your head, yes? Mm-hmm. Oh, yes, okay. Mm-hmm. Okay.
I don't do that all the time.
Yeah, when we assess psychogenic cough.
Well, true, but I mean, on a routine thing.
On a routine thing.
I don't always put a neuro. I do sometimes,
Yeah.
but not always. Interesting. Okay.
Alert.
That's
Well, it can be.
Now we know.
It can be, not
But
real
no.
extensive, but there needs to be some.
Like normal gait, alert
and oriented.
Something.
Okay.
We do,
Person
you know what, it's one of those things we don't even think about because it's so ingrained into the exam.
Right,
Right.
but not documenting it is
Right.
the problem. For
But
the
you
billing.
would document if it is not normal.
Oh yeah.
But
Yeah, that's why
Yeah.
it is not, yeah.
But if you don't document, it didn't
Yeah.
happen, so.
Correct.
Right. Exactly.
Very interesting.
Okay. Now you know.
Thank you, Paula.
So decision making. This is probably the hardest thing to decide. But let me just give you some examples. I think if you see a patient and you provide reassurance and you may write one prescription, that's pretty low level of medical decision making. But when you see a patient who has asthma, they've got shortness of breath, they have history of allergy, and you write a prescription, that's a little more complex. It's probably a level 2 of medical decision making. So it might be moderate complexity. So maybe the first one, you're writing a prescription, reassurance, that's probably low complexity. Then we move up to moderate complexity. Your high complexity is the patient that comes in wheezing, cyanotic. They're not moving air. There's some distress. You start the nebulizer. You're thinking about calling an ambulance, transporting them to the ER. You're thinking of future consultations you might need. That's a high complex case. And that probably is going to be your highest office visit code, the comprehensive, possibly because you're going to do a very thorough, quick assessment, physical exam. And then it's a very complex case. If you can't, the complexity is really what the patient presents with and how much you're thinking, your thought process. And I would still say that last case I mentioned with cyanosis and not moving air, and you're really working, you don't have to do you don't have time to do a whole review of history, you're doing, but it's still a comprehensive visit, and it's still a high complex case. So, as I mentioned earlier, there's two strategies to coding. One is by complexity of the key elements, and one is coding based on time. So here are the rules, and this patient one, let's just look at, this patient comes in for an asthma visit. They do have asthma, but they're not in distress. This is a follow-up visit. You spend 15 minutes counseling and coordinating patient care. You're educating them about their asthma, answering questions. You might review their action plan, talking to them about triggers. And this is face-to-face with you and the patient and a family member. You have taken a history. You have, done an ENT, exam, listened to their lungs, but it took 5-10 minutes. The whole rest of the time, you have been educating, training, counseling. So when 50% of your face-to-face time with that patient is doing that, then bill for time. And the way you do that is you document the duration of counseling, the duration of the visit, and you chart what you covered. So if you have an EHR, there's probably already that language in PowerChart or in your EHR, and you can just fill in the time and chart that more than 50% of this 27-minute visit was spent counseling and coordinated care regarding use of inhaler, avoiding triggers, etc. A sentence of document.
Plan.
Yeah, action plan. And it's usually one sentence takes care of what you've covered. So if you were just going to code this patient on an ENT exam and listen to their lungs, it would probably be a 99213. But if you code for time, it's going to be a 99214. Because you've spent, well, in the example, it was 27 minutes, but if you spend 25 minutes with that patient, only 5-10 minutes, and makes physical exam, the whole rest of the time is 50% or more is your expertise in working with that patient and family, then code for time. And you upcode. I know that's not appropriate to say upcode, but you're not really upcoding. You're documenting that your expertise and the complexity of what this patient needed at the time was more education, more training, more counseling from you. So you're the expert, you need to be paid for that work. So it's a 99214 based on time. Okay? Is that new for anyone? I'm just, hopefully it's not, and this is just a reminder, okay? Patient 2, another example, and I know this has happened to everyone, they're scheduled for an annual well-child exam, comprehensive head-to-toe exam with full history, and, in this example, a 99391 is an infant, young child. The parents probably is with this patient, and you're all set to, do the well child exam, code it 99391 with a V20.2, but the mother reports that, this child had reactive airway disease as an infant. She's concerned about some breath sounds that she hears. So now you have another medical problem to deal with. And there, you determined that this is an asthma exacerbation. You're spending separate identifiable time with another medical diagnosis. So you're normally, well child exam is one set, but now you've got another problem. So you add to your billing, your encounter form, a modifier for that second part of the work. So it'd be a 99212-25 is the modifier, and of course it's linking to a new diagnosis of 493.12. What's really important on this is that you document an E&M visit. So you've done your whole well child check, you've all got that documentation. You have to document that you did a more thorough heart lung exam, assessment of airways, and more treatment for the asthma. Okay? So use that modifier. I just included some of the other CPT codes that I'm sure you're already using. Again, my last point is if you use these, make sure your ICD 9 or 10 is linked to those. They won't stand alone. They won't get reimbursed if they are standalone. Okay? Here's another case. I'm trying to make this sort of practical. And if you come up with other cases, we can talk about that later. So this is a 12-year-old female who presents with expiratory wheezing, has a runny nose and a cough for 3 days, history of allergic rhinitis, used albuterol 2 hours ago. On physical exam, she has increased respiratory rate and pulse. ENT, she's got some clear nasal discharge. She does have wheezing bilaterally. You start nebulizer treatment, and you're going to observe her in your office to see that she post, the bronchospasm clears. So there's continued face-to-face contact intermittently over the next hour. Your nurse is probably checking in on her if this patient is being seen at a school-based health center. That provider is also going to be monitoring that patient, but the school nurse could also be intermittently checking on that patient. You've put in a call to a parent. You know that she's not being controlled, so you're maybe changing or adding the new prescription for a corticosteroid inhaler. Your parent arrives, you're giving updating the asthma action plan, scheduling a reappointment, coordinating care. There's a lot that's going on here. So her first visit, when her presenting problem is the 99214 with asthma exacerbation, and you include the allergic rhinitis. But because you've spent prolonged service in the office, face-to-face, for another hour, you can use this 99354. You also include the bronchospasm treatment, the 94640. You also include the medication, the albuterol you used with the J code and the NDC number. So there's a lot that you need to document with that patient to make sure that you're fully willing to get reimbursed for all that time and complexity of that. And here are the codes for that prolonged duration of time. If it's within 30 to 74 minutes, it's the 99354 times 1. You actually have to write that in. If it's beyond 74 minutes, you write the 99354 times 1 and you add the 99355 times 1. If it takes you up to, hour and a half, less than 2 hours. And then there are these codes for inpatient visits. I'm not familiar with those at all. I don't know if you all that work in the hospital are familiar with those. Are those
Well, we have-
commonly used? Or?
For us, for example, in the ICU setting, we use critical care time, and it's billed in increments of like 30 minutes. But yeah, 30 to 74 is a particular. I don't know if that's the same code, but it's billed at that, and then once you go over that 75-minute, then it's in increments of 30 minutes. I think that you just. But we don't have to. We just write the amount of time we spend,
okay.
and then our billers hopefully do
Right.
it correctly.
Well,
But
that's
there's that.
great. If you've got billing expertise at your side, that's helpful. Okay. Any other questions? I don't know if I've been going too fast, or this is probably all very familiar for you.
So I do have a question actually, because you said in this case, so this person's intermittently for 60 minutes. You're not there always in there for
Right.
60 minutes. Your nurse may be checking on them. What if your nurse is in there and giving them education for some of that time? Does that count in your billing time at all?
Is everyone able to hear that question?
Yes.
Okay.
They're still there. You know, and
You're
been
still
doing
there.
this,
You're-
yeah,
this-
and I'm still there.
Yeah. I don't know. I'm not sure about that. In other words, are you thinking if she's a certified asthma
Yeah,
educator
she's
or a
there
nurse
giving
educator who is,
asthma education
so could you bill for that education
in your time.
in the time? So it could be then more than the 60 minutes. You could extend that. So long as, I don't know.
Okay.
I'd have to. I really can't answer that.
I mean, if you're
I could see
in
it
the
either
room,
way.
I think you could if you're interjecting, but I don't know if you've left and you've seen 3 other people and then she comes. I don't know the answer to that.
Okay.
Yeah.
When you go in and out as a doctor, as long as you're documenting within the chart that the patient, the treatment started at 3 o'clock, I went back in at 3:15 or 3:30, and you continue to document that you've gone in and out, and you're covered.
So it doesn't necessarily mean you're like sitting there in the room for
No,
60
if you look
minutes.
at
No,
the definite,
no,
right.
you don't
okay,
have to be
right.
there.
As long as you're,
face-to-face.
it's
You're
clearly in the
checking.
chart that, yeah, that doctor went in there.
Multiple times to check on something.
Yeah,
Then you can bill which one when you do that?
The,
the 99354
Yeah.
or 55.
yeah.
Cool.
Yeah. Okay. Now, Kathy Mosley told me about this. I wasn't aware of this. If any of you have a certified asthma educator, this is a great service. 2 of our 4 managed care organizations for Medicaid, at least, and I don't know, is Blue Cross Blue Shield doing this for commercial patients? Patients
they
too?
did it for both.
Fantastic. We've got to get the other MCOs to commercial plans to cover this. This would be incredible. The certified asthma educators working under a physician order and using a standardized asthma curriculum can now bill for patients with Molina or Blue Cross. 98960, and that's for a 30-minute visit, and they can do group visits. So if there's counseling, teaching 2 to 4 patients, it would be 98961, and for 5 to 8 patients, 98962. The charting and documentation.
And we have respiratory therapists that are certified asthma educators that are doing this, except it just now got brought up that there wasn't a physician order attached to it. So some of them have been, because we have this referral process when they're in the ED and they get sent to the asthma education area. These people, they spend an hour with them, one-on-one kind of thing. And so then that just got brought up as far as there's no physician order for it. So now the way we're doing that, usually they call and get prescriptions and things and we take care of that. But going to try to make an automatic order under my name
Okay.
for these visits.
So these are patients that you do not do a consult?
No,
Right, okay.
This is just
Just
they
ED.
went to the emergency department. They were identified as having asthma. The respiratory therapist there refers them to the asthma education and management clinic that's run by respiratory therapists who happen to be certified asthma educators. They spend an hour with them. They help triage them and either give them their primary care or with us. And if they don't have appropriate therapy, they call the pulmonary division and we prescribe we give a couple months worth of steroids while they can get into their primary or to pulmonary. And that just got brought up as though where's the physician order for this education? So we're fixing that situation.
Does that have to be attached to every claim?
I
Be a
think so.
policy?
Yes.
Okay.
So now I will be claiming many things. But it's our protocol to
Right.
keep these asthma patients out of the ED. And in fact, we have been able to do that when they go to this asthma education management system.
Right.
We've decreased their relapse rate significantly for those that have gone through this education. So.
Well, that sounds wonderful. I can foresee with pay for performance, with the changes with the Affordable Care Act, as providers who decrease the ED use with their asthmatic patients, with hiring certified asthma educators, it's going to pay off. And it'll be really an incentive. Healthy asthma patients being kept out of the ED and having less time from going to work or
right,
out of school.
yeah.
And again, it's managing your population, and that's all going to be included with Affordable Care Act. So
Did these respiratory therapists have to become providers underneath?
They did become providers in our UNM system, as well as under, I believe they signed up to be providers under Molina. And we're now credentialing them through the hospital system as providers. So to kind of broaden the scope. Just for credentialing purposes, that doesn't really, I don't think, have anything to do with billing, but maybe it does. But yeah, they've registered as providers through Molina.
Even though they were affiliated with the hospital, they still needed to do
I
that.
think so, yes.
yeah, sort of like the registered dietitians, nutritionists that are working in outpatient clinics and practices. They also have to be contracted, credentialed, have the licensure. I have a question with this. I just have the CPT codes. What did they use for their ICD-9, the diagnosis? What the physicians, is that the physician's diagnosis?
Right.
It's linked to the 960.
And most of them have been because they were in for an asthma exacerbation, so then they do the 4930 or so for asthma, and then just an extensive education and spirometry and things like that.
So they used what they were seen with in the
ED.
Okay.
As a direct referral for asthma.
Well, and then in private practice, it really would free up the provider to go on
Absolutely.
and see other
patients.
patients, and the asthmatic patients are getting the best education and training.
Absolutely.
Yeah.
And in your system, qualified for those two reimbursers means that the person is certified?
Right. So all of the people that do that have the national certification, and we developed a standardized education protocol that's really based off of the PACE program or the NIH guidelines.
I wonder statewide how many we have.
45.
45. Oh dear. Is there a plan to increase?
Well, we've doubled it. Kathy and I.
Kathy?
Kathy and I have doubled it over a 4-year period, but the issue is the billing and reimbursement, and so it's not being reimbursed by everyone, and it's not known by everyone, and so why should people bother to go get this certification?
And the ones who are certified, when they do surveys, are half of them don't want to recertify
Because there's no point.
Oh.
They're not getting reimbursed
So
for
we
their
have to
services.
fix this
Oh,
structure.
okay. Well, then this is the next slide. That
Yes.
New Mexico Council on Asthma, working on improving the billing model. And then including maybe medical assistants that would go through training and education, get certified, pass the exam.
And
Maybe
sh-
office nurses who would want to do that.
I
Yeah.
have a question real quick.
Sure.
This is Cindy Colson.
Hi, Cindy.
Hi. I am an asthma educator, and I'm working up here with someone Peds on Mondays, and they give me referrals to do asthma education for their patients. And I usually meet with them for right at an hour. So in order for me to do this billing, do I need to become a provider? Should I try to do that through San Juan Peds? How would that work for me?
That was a UNM policy.
No, she's up in San Juan.
And
I wonder, I don't know if you have to be a provider through San Juan. I don't know. I wonder if you have to just register through their insurance groups. I mean, that's what our folks, one, they are providers at UNM, but two, they did register through Molina to get a specific provider number so that they could bill those patients. And I think that that's what they were looking at to do through press and the other groups. So I don't know if anybody else has insight into...
So that was my point. UNM has this policy, but other institutions and hospitals may have a different way to do this.
Right, right. So I don't know. That's a great question. I don't know if anybody else has a suggestion on what to do.
So right
They're
now,
affiliated with San Juan Regional, so I don't know. I guess I can talk to the clinic manager there and see how we should work this out, maybe.
I think that is an appropriate action because if at least you could be a provider for Molina and Blue Cross Blue Shield and then, get some, with the submission of those claims, get some reimbursement. I think San Juan Medical Center would appreciate that.
Yeah.
And as the council continues to work on this and get more health plans to cover it, but I agree. I think if you're not credentialed or contracted as a provider with the health plans, your service isn't going to be reimbursed.
Well, it can be under the doctor,
Under the doctor.
under the doctor, or the provider, the nurse practitioner.
I don't work. I actually work for American Lung Association. So
Oh,
she's getting paid now through a grant from
Okay.
American Lung, so I don't think she could do.
oh,
Like
that's
double
right.
or
That
something.
would
be
be-
an issue.
But
Try.
I think it'd be wise to talk to the hospital administration
Yeah.
though, because once grant funding runs out, I mean, because
Somebody
it makes
would
it very
help pay for it.
attractive
Yeah.
to them
That's
that
my
support
fear.
your salary.
Yeah.
Well, the other thing would be to see whether or not they would let you go ahead and bill while you're on the grant to build the cushion to keep your practice going once the grant's over.
okay, those are all good things. Thank you.
So how would you, how would the physician bill for that, for the asthma education?
The physician creates the order, and then that order goes to the asthma educator. The asthma educator follows the curriculum, and that is set, and then follows that with the patient, and then that code within the EHR, the code is submitted because it's been completed.
So it would be
The
So my
896.
physicians can bill.
Right.
And my referral form is enough for it to be a doctor's order?
If it's signed, if it's a doctor direction and signed by a provider.
Okay.
And you're using this, right, with Molina, you're using that. You've worked that
Yes,
out with them
exactly.
and through your organization.
Exactly.
Cool.
Okay. Well, thank you. I just have closing comments about counseling and remembering to document everything. And if you're not using some of these CPT codes that we've talked about, and give it a try. I think it's, we're all here trying to improve services and improve the payments that support the mission of providing excellent asthma care. So I hope some of this was a reminder or new information. Any questions or any other comments or particular patients you've seen recently that you might have questions about?
Is there any program set up that you're actually doing the asthma education via telemedicine, telehealth?
Not yet. I mean, ours,
Providers.
we had, mostly to providers, and then backing up their decisions, they would present their things. Some of our educators, like down in Lovington, did that, but it wasn't face-to-face with the asthma patient themselves. It was
Okay.
more just education for providers and support for the asthma educators to say, yeah, you're doing the right thing. When they had difficult questions or how to approach something, we had people come through with telehealth doing that. But we're not doing telehealth asthma education as of yet. Because it really needs to be a hands-on demonstrating how to do inhalers, and it's a little hard to get that from the telehealth way, I think,
Unless you
personally.
have a nurse.
That's there with them.
Yeah, if you have
Yeah.
a nurse who's, or an MA, as we're talking about, is trained physically on site, and then you have the nurse educator on the telehealth.
Well, but if you had somebody who was there on site that was trained, you wouldn't need to do it. I think I missed something. You wouldn't need to do it by telehealth if you had somebody there who was trained to do it.
Well, you could do, you could do the MA who's trained, or you could even if that MA wasn't
Oh, you're,
certified.
okay. I guess I was thinking higher level.
Yeah,
Yeah.
yeah, that's fine.
I know they've done it in Arkansas.
Do they use webcams or That would be ideal if in the office, the practice, there's a webcam with the patient and a medical assistant or someone, and then the instructor or the physician at the other end. Or Kathy, you could do it with.
Really.
So that is that how it works in Arkansas?
I don't know. I just know that there's a study that they've done.
Okay.
They,
And there's probably a CPT code thing
Telemedicine.
we could use.
yeah, Dr. Alverson says that anything that's billable should be billable by telehealth or telemedicine. So.
There's also some handouts. Do you want to go?
Yeah, I
over
was just
those,
going to say
Michelle?
there's a couple handouts that you were given. One is the one pager that has more has some pink on it. Let's see, it doesn't have the ALA logo. How about that? It's one that we had developed basically with help of UNM coders when we did this PACE program in around the state. So it just kind of is a one-page handout that says coding using time. And it talks, basically condenses everything that Paula just said, and then the code by time, how much time you spend with the patient as to what level of office code you use, compared to the code by the traditional key components. So this is just a nice little reminder and tells you exactly what is required for all the different history levels, exam levels, and medical decision making on the back side of that.
I have a coding hotline.
And then there's a coding hotline, and this is actually to the UNM medical group, but if you had a question, they said they would be glad to answer a question, or you could use hot codes at unmmg.org to get that answer to your question. The second handout is one that looks like Kathy has provided from the American Lung Association. And that one is somewhere. Crazy mouse here.
One item that I recently has been called to my attention is on the back side there's a code for an asthma kit. so you could bill for this asthma kit. And I've checked with Molina, and at least Molina says it's billable.
We give out spacers and
So
peak
you
flow meters
can
all the
bill
time.
that,
Yeah.
Yes. So this has a spacer, what, peak flow, a little video, a brochure. This is asthma kit. It's the second item on the last page. So I know that I haven't checked with any of the others, but Melina says yes, that you could use that.
Spacer asthma kit.
Yes.
Okay.
So you can-
But isn't
S8097.
that part of our respiratory things?
Cool.
I don't know if they charge it.
I thought that was.
All right. Any questions from participants online?
I think our RTs charge for the spacers, right? That was part of the
It's part of
overall
the
cost of
spirometry, I
spirometry. Okay.
Other questions? No?
Okay, thank
Okay,
you very
then.
much.
Thank you.
Thank you.
In 2 weeks,
And in 2 weeks
March 22nd.
is our next topic, and it's still up for discussion because our presenter is actually ill, and so we're going to change it around a bit. So it'll probably be environmental and allergy and immunotherapy, but we'll let you know then.
And also, has anybody else joined us since we signed everybody in at the beginning?
So you can get your CEU
Do you have to be signed in?
CMEs.
and CMEs.
Dr. Kazimsap?
Hi, this is Pawita Kazemsa from Rio Rancho.
Hi, Poeta.
Thanks for signing in.
And as a reminder, starting in April, we'll be switching to Wednesdays at noon instead of Fridays, but we will have our regularly scheduled APT clinic in 2 weeks and topic possibly to be determined. Thank you very much.
Thank you.
Thank you.
Thank you.